Ladies and gentlemen, esteemed medical students, welcome to today's lecture on Lewy body dementia. In this comprehensive session, we will delve into the intricate details surrounding the neuropathology, clinical presentation, diagnostic criteria, pathogenesis, and various management strategies of this debilitating disorder. Let us embark on this journey of knowledge, exploration, and understanding. Lewy body dementia, LBD, is characterized by the presence of Lewy bodies, which are abnormal protein aggregates, primarily composed of alpha-synuclein. The deposition of these Lewy bodies in specific brain regions, including the cerebral cortex, substantia nigra, and limbic system, leads to the disruption of neuronal function and subsequent clinical manifestations. Additionally, the Lewy bodies exhibit a granular appearance when visualized under the microscope, emphasizing their pathological significance in LBD. The clinical presentation of LBD is marked by a combination of cognitive, motor, and psychiatric symptoms. These symptoms often overlap with those of other neurodegenerative disorders, making diagnosis challenging. Key features include a fluctuating cognitive decline, recurrent visual hallucinations, rapid eye movement sleep behavior disorder, RBD, and Parkinsonism. Diagnostic criteria, such as the McKeith criteria, assist clinicians in accurately identifying LBD by considering the constellation of symptoms and their chronological sequence. Alpha-synuclein, a small protein primarily expressed in presynaptic terminals, plays a pivotal role in the pathogenesis of LBD. Mutations, duplications, and triplications in the SNCA gene, which codes for alpha-synuclein, contribute to the familial forms of LBD. Furthermore, abnormal aggregation and misfolding of alpha-synuclein lead to the formation of insoluble Lewy bodies, disrupt synaptic function, and trigger neuroinflammation in affected brain regions. The propagation of alpha-synuclein pathology throughout the brain further exacerbates the clinical manifestations seen in LBD. LBD is associated with dysfunction of the cholinergic system, particularly the loss of cholinergic neurons in the nucleus basalis of Maynard. Acetylcholine depletion contributes to the cognitive impairment observed in LBD. Additionally, disturbances in the cholinergic system can lead to visual hallucinations due to dysregulation of visual processing pathways. Treatments targeting cholinergic deficits, such as acetylcholinesterase inhibitors, have shown promising results in ameliorating cognitive decline and hallucinations in patients with LBD. Neuroimaging techniques, including structural and functional imaging modalities, play a crucial role in supporting the diagnosis of LBD and differentiating it from other neurodegenerative disorders. Magnetic resonance imaging often reveals cortical and subcortical atrophy, particularly in the occipital and parietal lobes. Single photon emission computed tomography, SPECT, and positron emission tomography, PET, scans can demonstrate reduced dopamine transporter activity in the basal ganglia, substantia nigra, and cortical regions, confirming the dopaminergic deficits associated with LBD. Distinguishing LBD from other neurodegenerative disorders, such as Parkinson's disease, Alzheimer's disease, and vascular dementia, poses a diagnostic challenge due to overlapping clinical features. Careful assessment of symptom onset, progression, and cognitive profiles, combined with neuroimaging and biomarkers, aid in reaching an accurate diagnosis. Collaborative efforts between neurologists, geriatricians, neuropsychologists, and other specialists facilitate a comprehensive evaluation of LBD and its differentiation from similar conditions. The progression of LBD varies among individuals, but it generally follows a pattern of gradual deterioration. Cognitive decline, motor dysfunction, and psychiatric symptoms tend to worsen over time, leading to significant functional impairment in daily activities. Disease progression is often punctuated by acute exacerbations, known as fluctuating periods, during which symptoms may rapidly worsen and then fluctuate in severity. Understanding the natural course of LBD is essential for appropriate care planning, prognostication, and timely intervention strategies. Managing the complex and diverse symptoms of LBD necessitates a multimodal approach. Pharmacological interventions targeting cognitive impairment and motor symptoms include acetylcholinesterase inhibitors, levodopa/carbidopa combinations, and atypical antipsychotics. Non-pharmacological strategies, including cognitive rehabilitation, physical therapy, and occupational therapy, play a vital role in improving functional abilities, enhancing quality of life, and reducing caregiver burden. Individualized treatment plans should be tailored to the specific needs of each patient while considering their overall health status and potential side effects. Autonomic dysfunction is a common feature of LBD, affecting various bodily systems such as the cardiovascular, gastrointestinal, and genitourinary systems. Orthostatic hypotension, urinary incontinence, constipation, and abnormal temperature regulation are frequently observed in individuals with LBD. Careful management of autonomic symptoms is essential to prevent complications and optimize patient well-being. Supportive measures, lifestyle modifications, and targeted pharmacotherapy can ameliorate autonomic disturbances, thereby improving the overall quality of life for individuals with LBD. The impact of LBD extends beyond the affected individuals to their family members and caregivers. The demanding nature of caregiving in LBD, characterized by cognitive impairment, motor fluctuations, hallucinations, and behavioral disturbances, often leads to caregiver burden, anxiety, depression, and decreased quality of life. Providing support to caregivers through education, counseling, respite care, and access to community resources is crucial in maintaining their well-being and ensuring sustainable care for individuals with LBD. Continual research efforts are focused on unraveling the pathophysiology, refining diagnostic criteria, and identifying potential therapeutic targets for LBD. Advances in biomarker development, neuroimaging techniques, and genetics are leading to improved diagnostic accuracy, early disease identification, and personalized treatment approaches. Furthermore, ongoing clinical trials are exploring novel pharmacological agents targeting alpha-synuclein aggregation, neuroinflammation, and synaptic dysfunction, with the ultimate goal of slowing disease progression and providing effective disease-modifying therapies for individuals with LBD. LBD is a progressive neurodegenerative disorder with an unpredictable course. Prognosis is influenced by various factors, including the age at onset, disease severity, and comorbidities. Palliative care plays a vital role in addressing the physical, psychological, and social burdens associated with LBD. A holistic approach, emphasizing symptom management, patient comfort, and support for caregivers, ensures that individuals with LBD receive empathetic and comprehensive care throughout the disease trajectory. In conclusion, our journey through the intricate world of Lewy body dementia has encompassed a comprehensive understanding of its neuropathology, clinical features, diagnostic criteria, management strategies, impact on caregivers, and future research avenues. Armed with this knowledge, we are better equipped to contribute to the early identification, accurate diagnosis, effective management, and compassionate care of individuals living with Lewy body dementia. We must continuously strive for further advancements in research, clinical practice, and supportive services to improve the lives of those affected by this challenging neurodegenerative disorder.